The first thing we're going to do is actually a free write. So why don't you go ahead and get started on that. Take out a piece of paper. This is for you only, not for anyone else. I'll introduce myself in a minute, but let's start with what do we mean by race-based medicine? What is it, and why do you think it's a problem? Okay, so I'm Carolyn Prouty. I am a faculty member here. I teach in public health and health sciences. And here, okay, not here, was going to be Pauline Yu, who's a faculty member in marine biology. And unfortunately, Pauline was ill at the last minute. So I'm, with the support of my colleagues, gonna try to present both of our material. And what we're going to do this morning is spend some time looking at the relationship of biology and race, and in particular, looking at race-based medicine and answering these questions, what it is and why it's a problem. I'm going to go through some framing material. We're going to watch the video, and a video that is a TED Talk of Dorothy Roberts, who's a sociologist and legal scholar and amazing thinker in this arena. And this title is really taken from the title of her TED Talk. And so we'll watch that, and then we'll have some time for discussion and lots of time for your questions. So that's where we're headed, okay? Okay, so we did this. So as a way of sort of marking, where do we start with this? One of the things that the point of this is that we are steeped in all kinds of ideas about race and biology. Some of them are very confusing, and they're impossible to escape. And I hope to take on and challenge many of those ideas and have us recognize that we have in our bodies many of those ideas, and that we get a chance, that part of our job, I would say, is to make a distance between those immediate things that our body knows about race and really embrace our, as I was just talking about in my class, our neocortex, our brain, and recognize that we have ways of overcoming these ideas that are embodied in us, and so do healthcare providers. And that's what we're going to look at. How are those ideas embodied, particularly in healthcare providers and in our healthcare system? Okay, so I want to start with something to give an idea of what's the problem. To start with this, and I should say, so my background is I'm a veterinarian. I'm still practice some, and I have been practicing for 27 years, a long time. And when we're in vet school, it's the same as in medical school. You're taught, when you're describing cases, one health professional to another, you use what's called the signalment. And so you would describe a case starting with, so I might describe a case starting with, this is a 12-year-old male Shih Tzu, okay, but we're not talking about that. So we might say in veterinary medicine, but in human medicine, what generally, as you were going to describe something that's going on, you would name three things about a patient. You would name their age, their race, and their gender. Usually in that order. That's why I put them in that order. So you would say this is a 42-year-old Asian male. This is a 3-year-old African-American female. Like, that's the way that you start a case. Who's presenting with these symptoms, and who we did these procedures on, and who we're suspecting has this condition. But that's how it started. And so I want to just dissect that a little bit and begin to engage this question of, why is this a problem that of the three things that we initially say we need to know about every patient, that one of them is race? So age makes a lot of sense that we put that there. It has us know there's a lot of different susceptibilities to different kinds of diseases and conditions. What age we are says a lot about what possible health conditions we may be experiencing. So that one makes a lot of sense. Gender has a few different implications, and I'm not going to take on all of the assumed gender questions, which are really important. But one of the things that it does is it does tell us something about, at least often, some biological state. And we do experience some health conditions, relatively few, but different biologically, depending on our sex. should have put sex, not gender, sex. And that it also does give instant pronouns so that we begin after that to say she or he in that binary system. Again, I'm not going to take on the problematics of that because that's not the topic of this talk, but another important topic. So age and sex, which are often conflated with gender, those two make some medical sense, one could argue. Race is, first of all, assumed. So we don't ask, we might ask people's age. You may well, if you're filling out your form, ask people, so medical forms I'm talking about, not other forms. You may well identify a sex, but rarely would you identify a race, and yet it's likely to be assumed by a healthcare provider. They're going to look and decide who you are. May ask, but often will decide. And what I wanted, part of the point of this talk is we're going to really take on, it really means nothing biologically in many ways, and it also is important. So we're going to kind of try to bring into that's confusion. There's a really, an excellent article, it didn't get into, okay, I know it didn't get into this because this was Pauline's version. Okay, so I'm going to refer to, and if you are interested, I'm going to refer to an article that was in, an op-ed that was in the, article that was in the Chronicle of Higher Education in 2003, written by Richard Garcia, who's a pediatrician. And the title of his article is "The Misuse of Race in Medical Diagnosis." So I want to bring some cases in for why is this so problematic? Why is it such a problem that we have, that we're talking about, that we use race in our signalment? So he says the identity of patients, I helped train medical students and residents who were all taught, as I was when I was a medical student, to assess each patient in terms of age, race, and gender, always in that order. A 52-year-old white female, a 3-year-old Asian male, 3-month-old Asian male, etc. The actual identity of patients remains ignored. A 47-year-old African-American female who's never been to Africa and prefers to call herself black if ever asked by a white doctor, which she never is. To a 2-pack-a-day smoker still living with her mother in South Central LA presents with fatigue. So you can see that when we ask and what we ask about and what we don't ask about and what we assume, so the doctor looks at the patient's skin, nose, hair, lips, the silent mouth, and defines ancestry, and I'm going to distinguish ancestry from race because this is an important part of this, understanding all of this. In a single word: Asian, Hispanic, white, African American. He says in this article, I smiled when one doctor described the Nigerian father of a patient as African American. The Nigerian father didn't smile. So here's the problem. The problem is that though we're taught, healthcare providers are taught in nursing school and medical school and other places that there are certain diseases that are more prevalent in certain races. And just to get to what the problem with that is, race is used as a proxy for ancestry, and it shouldn't be. So we're going to look at that in more particular. So, but here's an example of where we might go wrong. So we might make assumptions about sickle cell anemia, for instance, which is associated with African Americans, although it's 30% of people from Mediterranean origin. That area of the world actually have the genetics associated with sickle cell anemia. He says in this article, my childhood friend Layla wasn't diagnosed with cystic fibrosis until she was 8 years old. Cystic fibrosis is a disease of the lungs in particular. It's about not being able to make mucus that's thin enough that it can do the things that mucus is needed to do. And so respiratory problems are prevalent. And it's thought of usually as something that strikes white people. So over the years, her doctor had described her, quote, as a 2-year-old black female with fever and cough, a 4-year-old black girl with another pneumonia. Layla is back. This is from a medical record. Had she been a white child or had no visible race at all, she probably would have gotten the correct diagnosis and treatment much earlier. Only when she was 8, she'd been having symptoms since she was 2. Only when she was 8 did a radiologist who had never seen her face to face, notice her chest x-ray and ask, who's the kid with cystic fibrosis? Instantly noticed it. But that was a way where it was led people down the wrong path. So he finishes this by concluding, we learn nothing if we group together as Asian Americans, for example, a man in Seattle who was born in the far eastern portion of the former Soviet Union, a Korean woman living in Toronto, and a child in California with maternal grandparents who immigrated from China, and a father whose ancestors came to New Jersey from Europe. There are almost as many definitions of Hispanics as there are Hispanic. Do I have the same genetic risk for sickle cell anemia as a Puerto Rican, a Spaniard, or a Mayan? So I want to help, that's a beginning of an introduction to what's the problem with race-based medicine. This is just about diagnosis. I'm going to go through a little bit more, and the TED Talk will talk a little bit more about not just diagnosis, but treatment and prescribing and other areas. But I wanted to sort of make clear, this is part of what we're talking about, okay? So where we're headed with this, these are the 3 points that I'm going to cover in my next few minutes. Race is not biological, and I'm not going to take on all of that, but I'm going to just at least bring up some of the common questions, especially for science students who know something about genetics, and it's confusing. It's legitimately confusing. So I will just say race is not biological, period. It is socially constructed, and we're going to look a little bit at that, and there's lots more to learn about that. I also want to bring in the question about health and health care and its relationship, because we're concentrating on health care, and part of the problem of race-based medicine is that it's a very narrow look at health. And then finally, end with race-based medicine is unscientific and worse, displaces the legitimate focus on racism as what truly interacts with health. Okay. So that's where we're headed. So from the TED Talk we're going to watch, Race and Health, this is a quote from that. You see, race is not a biological category that naturally produces these health disparities because of genetic difference. Race is a social category that has staggering biological consequences. But because of the impact of, not because of genetic difference, but because of social inequality, the impact of social inequality on people's health. So let's look at this for just a minute. So race, this is legitimately confusing. And this is what we addressed last year at a similar session, took on the idea, spent the couple hours looking at this question of that race is not biological, and yet it lives in our bodies, and how is that true? And that's just what Dorothy Roberts' quote was just saying. So race is socially constructed, is an idea who belongs to what race, what it means that we belong to different races. These are ideas. These ideas do have impact. So it's not at all that race doesn't matter, but it's not biological. And here's what's really confusing. Skin color has some biological, has biological definition and is determined biologically, right? So there is genetics of skin color. There's genetics of hair shape. There's genetics of eye shape. All of those have genetic bases, but that's not what race is. So race is not those very superficial biological characteristics. And that's what gets confused when we make decisions about biology. We make decisions about people and who they are as biological genetic beings based on these very superficial traits that don't map onto anything that we think of as important in other ways. They are superficial, and in fact, is there some geography there? There's geographical influence, but it is not, but race as an idea is about our identities and how people look at us and perceive us, and that isn't biologically determined. So when we get into the question part, we can take that on more, but I'm not going to go further into it. There's lots more to learn. I want to recommend, again, didn't get into this version of it, but not that you can see, it's a black book. Okay, but I'm going to tell you this book. It's called Fatal Invention. This is Dorothy Roberts' book, and I highly recommend it. Fatal Invention, the subtitle is How Science, Politics, and Big Business Recreate Race in the 21st century. For me, it's one of the best books for really deeply exploring this question. The first part of the book deals with this very definitively and in great detail and with great respect about how is it that that's true, that race is not biological and yet it lives in our bodies. And what she does for the rest of the book is look at how is it that science continues to use race in research, and particularly in genetic research, mistakenly continuing to conflate race and genetics. Okay. All right, so we can take this up again more when we have the open time for questions. Okay, so I want to spend a little bit of time. I talked about this a little bit last year for those of you who are here, but I want to, as a public health person, I want to make sure that we're clear about what are the things that that do determine our health, distinguished from health care. So here's a list of some of the things that we think about that determine our health, and these are put together by the Public Health Agency of Canada. There's a website there, excellent website, that goes through all of these different things that we think about when we think about, and that do determine our health. So I've listed them to some degree in the order that we tend to think about them. So when you think like when we think about like how we hold as a society, what influences our health? We think about, first of all, the things that we are responsible for. So what do you eat? How much sleep do you get? Do you exercise? Do you smoke? Do you drink? Do you do other drugs? So those kinds of things we list very high in terms of what influences our health. And there's not a question that they do, but we're going to look at the rank of where things really do in just a minute. We think a lot about health care and how important health care is. We certainly think about biology and the question about how much of our health is about genetics, and are we healthy because we had strong grandparents? Income and social status, education and literacy, employment, working conditions, where we spend our time definitely have our really important influences, social and physical environments. How we developed as a child, very important. There's a lot of campaigns, you sometimes hear about them being talked about the first 1,000 days of life. That includes all of our prenatal life, as well as our first 2 years outside of the uterus. And social support networks. So these are roughly the most important things that do influence our health. And what this Public Health Agency of Canada did was actually put them roughly, looking at a lot of metadata, put them in order. So I'm going to reorder these in terms of which are the most important in terms of determining our health. Okay, so that roughly is the order in which the things that have the biggest influence on our health actually influence our health. So if you look at all of those on the top, income and social status, sometimes called socio-economic status, SES, social support networks, who we spend time with, who we can call on when we're having stress and other problems, education and literacy, a huge influence on our health, employment, working conditions, social and physical environments, and those are sometimes grouped together and called the social determinants of health. And it turns out that they roughly probably control more than half of our health. Estimates are around 60% of our health is determined by those, and not biology and genetics, healthcare and access, which is actually of the ones that are listed, the least important, but the least important in those are personal habits and all the things that we hold others and ourselves responsible, our personal health habits and coping skills, okay? So just a way to shake up and think about what it is that, what is it's actually living in our bodies. And it turns out that much of it is about the environments that we're in. Okay, so that's part one. Part two, race in medicine. So now I want to spend a few minutes taking on race in medicine. And here again is from this TED Talk. The problem with race medicine extends far beyond misdiagnosing patients, as I talked about at the beginning. Its focus on innate racial differences in disease diverts attention and resources from the social determinants that cause appalling racial gaps in health. Lack of access to high-quality medical care, food deserts in poor neighborhoods, exposure to environmental toxins, high rates of incarceration, experiencing the stress of racial discrimination. So I'm going to talk some about race-based medicine and what that is, but one of her basic points is, part of the problem is that we're not paying attention to the list that I just talked about. If we were going to look at the most important signalment, we would say our age, our gender perhaps, or our sex, and our socioeconomic status, our employment status, our level of education. That's likely to give healthcare providers some of the most important ideas about what's going on in our bodies. Okay. So race-based medicine, part of the problem and part of the big supposition behind it, and I'm not going to go into all the different examples, is again what I alluded to at the beginning, that race is used as a proxy for ancestry. In other words, that we think that, healthcare providers think that they can look at somebody and by their skin color, shape of their hair, color of their hair, shape of their eyes and lips, decide something about who they are biologically. And so it's used as that proxy for ancestry. And ancestry here, we're talking about a statement about an individual's relationship to other individuals and their genealogical history. In other words, ancestry is genetic. So we can say things about genetics and ancestry by definition. That's what ancestry means. But we use ancestry, we conflate ancestry and race. That's the problem. Race is a pattern-based concept that has led scientists and laypersons alike to draw conclusions about hierarchical organization of human beings. I'm going to see where which connect an individual to a larger, preconceived, geographically circumscribed, or socially constructed group. In other words, race is socially constructed. It's a pattern, but patterns, when we're dealing with individuals, let's hope that that's who all of us want to be seen as and treated as. What's my health problem? Mine as an individual. And when I'm taken as a part of a pattern, that's the problem. I'm not being seen as the individual who I am. An individual is going to, something about my ancestry, do my ancestors have certain genetic markers? A valid medical question. That's not race-based medicine, that's using genetics. And a lot of people do that in a lot of different arenas. Race-based medicine is conflating race and ancestry. Okay. There's an excellent two-page article that Udell et al. Have recently published in Science just a couple of months ago that goes through this and talks about not just race-based medicine, but really what does it mean to use race in science, and what standards should we be using in publication, things that name race. And maybe I didn't say this. So it's not that I think that people who are talking about this are not saying that we shouldn't be talking about race at all, because race is really important. It's important because of racism and people's experiences and how it does live in our body. And so as Dorothy Roberts said here, experiencing the stress of racial discrimination amongst many other things, that does have effects, and racism is real in our society, and it does live in our bodies. So do those end up being important biologically? Yes, but do we want to, in race-based medicine, decide something about an individual, which we're using as a lazy way of thinking about, that's another word for proxy, lazy way of thinking about somebody, what I might know about somebody's genetics. That's the problem, okay? And it leads to errors in diagnosis, errors in treatment, errors in prescribing. I'm gonna go into a little bit more specifics about a few of those. So racism, race-based medicine, and I want to distinguish between, actually I'm gonna go back to this. So what I was just talking about as problems with race-based medicine. So I named some at the beginning about diagnosis, how it might lead us in the wrong direction. Errors in treatment and errors in prescribing, I'm not going to go into in detail, but again, it's going to be similar things based on if I am conflating and thinking about somebody as from a certain race and deciding that they have certain conditions, and I've decided then what I'm going to do, and this, then that's going to be again related to race. That's what we're going to call race-based medicine. It's very related to, I'm going to move on to this part, racism in medicine, in healthcare. They're very closely related. So two main parts of it that I'm going to describe. One is the whole idea of implicit bias. And this is what I was referring to at the very beginning, that when we all have implicit bias, that's the bias that comes up when we live in a racist society as we do. We make associations without voluntarily that happening. So when we think of someone who's African American, or we think of someone who's Hispanic, or we think of someone who's Asian, or we think of someone who's white, immediately, as I said those words, your brain made synapses. Without your trying, it made certain connections. That happens pre-consciously. And in and of itself, there's nothing wrong with it. Now, there's a big wrong, which is that we want to tackle racism in our society. But to blame ourselves for having that biological reality doesn't probably make a lot of sense to spend time on that. What we want to do with it and how we act on it and how we recognize it, that's where we want to spend our time. So it's true that we are going to have implicit biases. Health providers are going to, faculty are going to, administrators are, students are, every person in our society is going to have some of these because this is the soup that we live in. What we do with it, again, is our choice in it. So what it leads to, there's a number of different, lots and lots of different examples of what this ends up looking like in the delivery of healthcare. One that was just, you may have heard, some of you may have heard it on the news yesterday, so I'll just bring it as the latest example. You can hear about this all the time. A misperception of pain tolerance. So there's an idea that African Americans have a higher tolerance to pain. And it's been well proven long before this particular slice of research that was done that African American patients tend to be given less pain medication, different kinds of pain medication, and it's based on, at least in part, what this particular research said was, yes, it is indeed based on implicit bias, that it is, there's some idea that it's also about beliefs about, again, implicit bias, about likelihood of becoming addicted and problems with that, but it's partly about and it's also about implicit bias and beliefs about tolerance to pain. And I probably won't show it today, but if you look at the history of these ideas of biological differences in tolerance to pain, can you hear the connection to slavery? Can you hear the connection to the willingness to inflict pain on another human being? And if you thought that somebody had a different tolerance to pain, would that be more tolerable for you? So you can hear the history, the ringing through these ideas. It ends up manifesting as less time with patients, less involvement in medical decisions, many more. There's a couple just 2 years ago in 2014, end of 2014, the New England Journal of Medicine had a couple of really good summary articles that really looked at and spelled out a number of these different biases in the delivery of care. It shows up in end-of-life care, beginning of life care, all the way through end-of-life care. It's a part of all of it. And part of the problem, here's the reference there, is that it ends up also meaning that there's less effective care for people of color. For almost every disease studied, Black Americans received less effective care than white Americans. These disparities persisted despite matching for socioeconomic and insurance status. So this is about what happens when a patient who is a patient of color, and particularly African American, what happens when the physician who is likely to be, not just by numbers, white, what happens. And I will say that when this New England Journal of Medicine, and some of the other research says this happens with roughly 2/3 of physicians specifically when they study it. So some people have figured out how to overcome their implicit biases. And I'm guessing that the 2/3 don't, it's not the same 2/3 all the time, right? There's probably, different times when we're more aware of it and less aware of it. It is possible to use awareness as one of the many tools to work with this and to work against this. Okay. This article that it's in Science asks, brings up a couple of sort of general things that we want to learn from this and issues. And what they do is look at, they make a few suggestions for what we want to do in science, and science broadly as well as medicine specifically. So they say the focus should be on racism, the social relationships, rather than race, which is this supposed biological predisposition, in interpreting racial effects. So if we're looking to try, as we publish all kinds of different data about differences in race, that we want to make sure that we're looking at through the lens of racism rather than some kind of biology. And this is part of where it really, this is really sticky stuff. It tends to really persist. That the failure of scientists to recognize self-identified racial categories versus assigned or assumed ones. How, and you will hear about this at the beginning of the TED Talk, how did you decide in the first place when you're doing your research what race someone was? Self-identified race? Did you use some genetic marker? Problematic. So even looking at how that, what it is was it the perception of the researcher? So one of the many places where science has been very muddied by all of this. And then a concern about the haphazard use and reporting of racial ethnic variables in genetic research. And this is really, it's used to justify the use of racial categories. So sometimes people will use these genetic markers, and this is what Dorothy Roberts takes on in her book quite a bit, that people think that they've identified markers, genetic markers, that again are used as proxies for race, when in fact, they're often not even precisely about ancestry. So it gets this is one of the many areas where they're quite confused. Okay, great, we're doing great for time. Okay, so I'm gonna present a little bit about what Pauline was gonna talk about here. And she wanted to raise, and I will just say, I will take it over, it's mine too. This is a really important question in this. When we're looking at, what is disease and what is health? What's normal, in other words, health states, and what's abnormal? All of the assumptions that we start with in medicine ask this question, and of course we ask it, I hope we're asking it in all of our classes, and we're asking it in many more arenas than just science and medicine. But deciding what is normal and who is the default human, it matters a lot when we're looking at measuring people biologically. So there's really big different consequences of treating different people as a reference for all groups. So when we take white males as the reference group, what does that do to what we decide is normal? And this is not just in psychological research, though it's certainly there. There's a lot of historical use of actually even racial differences. Dorothy Roberts will talk about this in breathing apparatus. There's a whole glomerular filtration rate, if you've studied kidney function, that there's actually on printouts still to this day in different, you may get a lab report, the glomerular filtration rate, GFR, which is about kidney function. It'll be a range of what's normal for Caucasian people, for African Americans. Like, it'll actually try to interpret it that way. So there's lots of lingering places where this happens. And when we use, we can continue to talk about, so what are the problems, what happen when we assume, even just biologically, I mean, there's lots of problems with assuming that who is normal is a particular group, and in particular the dominant group, whites, and often in research, white males. it does bring in this idea of that we were just talking about, both conscious and unconscious bias, and the assumptions that we make. That's part of what's behind those implicit biases, the assumptions that we make, and how we fail to see people as individuals, how it is that our assumptions end up running us, and end up reinforcing the already structures that we have that are having people show up differently in our office if then we use these biases influence our decisions. It continues to reinforce and reify these structures. So one of the next place, or the last place before we watch this video that I want to look at is, so what is it? So if people aren't taking on, if healthcare providers aren't taking on their biases, we tend to want to judge them for what it is. And I want to present just a little bit of a bigger picture of what happens in healthcare delivery. Why is it that this is so easy to do? Why is it that physicians, and in particular, but physicians and nurses and other healthcare providers end up using these proxies? Why do we have race-based medicine in its use? And part of what I want to say is time. So the putting these together, what's one of the things that's really changed and that really structures the way that people interact with their healthcare system is how much time do you have with a provider? If you want to be seen as an individual, how long does it take to be seen and known as an individual? Probably longer than 10, 15 minutes, which, if you're lucky, is how long you might have with that healthcare provider, right? So why is it that that's where the way that our that's the system within which physicians are operating? So doctors, patients, professional systems, in that way, and looking at how our healthcare system is shaped by policy, is shaped by our economy. So government and corporate bureaucracy has shaped how this has gotten a hold, and because of that, time pressure. Economics as well, and time in particular. So efficiency at what cost? And the way that it is that this has happened, just do this last, is that when this happens and people aren't getting enough time, and there isn't barely enough time to even engage your implicit biases, make decisions not based on those, but putting those to the side and finding out about the individual patient that's in front of you, it ends up reinforcing all of these structures, increasing inequality because there's not good delivery of healthcare, because there's implicit bias and because there's less effective healthcare. It then reinforces all of these ideas and all of this inequality, resulting in healthcare delivery and outcomes. So it's part of the system keeps reinforcing itself because of these, in part because of these structures. Okay, I hope you have questions. I hope you're brimming with them. I want to take, the next thing we're going to do is watch, see if I can make this happen. We're going to watch this TED Talk. Let's take a few minutes to talk with each other about that and continue the other discussion, and then we're going to have some discussion together, okay? So take a few more minutes to formulate your questions, share your thoughts. Okay, why don't you wrap up your conversations, if you will. So we've got a good long time for questions and discussion, and I'm going to say also just really want to call on my colleagues and others in the room. I want to host this discussion, but by no means am I the only expert in the room or the only person. So I just really invite lots of participation.